A 76-year-old woman is brought to the emergency department by ambulance due to confusion. Her husband says that she has metastatic esophageal cancer and has been unable to eat or drink for the last few days. Yesterday, she became increasingly lethargic, and today, she is hard to arouse. Temperature is 37.1 C, 98.8 F, blood pressure is 80/30 mmHg, pulse is 60/min, and respirations are 30/min. Pulse oximetry is 95% on room air. The patient appears lethargic but opens her eyes to verbal stimuli. Mucus. Membranes are dry. A peripheral IV is placed. Laboratory studies are ordered. And intravenous fluids are started. An ECG tracing is shown in the exhibit. Which of the following is the best next step in management? This patient with diminished food and water intake developed dry mucous membranes, hypotension, and confusion, indicating hypovolemic shock. Severe hypovolemia often causes significant electrolyte abnormalities: hypernatremia, hyponatremia, hyperkalemia, metabolic acidosis, due to gastrointestinal electrolyte losses, increased antidiuretic hormone secretion, and/or acute kidney injury. In this case, the presence of no P waves and a sine wave pattern on ECG is consistent with hyperkalemic emergency. Hyperkalemic emergency usually arises when serum potassium is more than 6.5 mcl. It is marked by altered repolarization of skeletal and cardiac muscle, which leads to lethargy, muscle weakness, cardiac arrhythmias, and/or progressive changes on ECG. Peak T waves, loss of P waves, widen QRS, sine wave pattern, asystole. Patients with hyperkalemia-induced ECG changes require urgent treatment with calcium gluconate to stabilize the cardiac membranes and insulin plus glucose to drive potassium into cells. This temporarily counters the cardiac abnormalities, which provides time for removal of potassium from the body via stool, pataromer, urine, furosemide, and/or blood, hemodialysis.
There are 3 ways to reduce potassium. Insulin's one, calcium gluconate is another. What's the other one? What's the other one?
Hyperkalemic emergency causes characteristic progressive changes on ECG. Peak T waves, loss of P waves, widen QRS, sine wave pattern, asystole. Patients with hyperkalemia-induced ECG changes should be urgently treated with calcium gluconate to stabilize the cardiac membrane and insulin plus glucose to move potassium into cells. Longer-acting therapies to remove potassium from the body can then be administered. Medicine. Subject. Cardiovascular system.
I'm Googling ways to reduce potassium. Yep, sodium. Okay, yeah, sodium came to mind. IV insulin and glucose. Wow. Apparently in albuterol as well. So apparently albuterol, sodium bicarb, but the answer for the 3 things to reduce would be sodium bicarbonate, calcium gluconate, and insulin, and I guess with glucose, with the 4th one being albuterol, which I don't really understand how that works, but some other things that, okay, so that's the rapid acting. Slow ways to do it are diuretics, sodium bicarb, albuterol, sodium zirconium cyclosilate, Lokelma, which binds to potassium in the intestines, sodium polystyrene sulfonate, which is K-alex K-exolate. K-exolate, which removes potassium through your intestines before it's absorbed. So it's kind of like basically Veltassa and the other one. Okay, got it. I marked the ones that like I want to come back to and then make a Anki card on.
A 50-year-old man with a long history of chronic alcohol use disorder is hospitalized due to nausea, vomiting, and epigastric pain lasting for 2 days. The patient was previously admitted with an episode of alcohol-induced acute pancreatitis. Temperature is 37 C, 98.6 F. Blood pressure is 102/70 mmHg. Pulse is 106/min, and respirations are 16/min. BMI is 17.5 kgm2. On physical examination, he appears cachectic. He is alert and oriented. The chest is clear to auscultation. There is epigastric tenderness. Without rebound, bowel sounds are present. Neurologic examination is normal. Laboratory results are as follows.
I don't know what this means. It's not pancreatitis. Well, it could be. Lipase doesn't need to be elevated. The fuck would he need a lumbar puncture for? He's hypo everything. Hyperkalemic if you were trying to go for like ACTH, I think. Serum phosphorus? I mean, I guess. This guy has refeeding syndrome? Oh, I see. Right there.
BMI is 17.5 kilograms per meter.
Okay, interesting.
This patient with chronic alcohol use disorder developed diffuse weakness and hyporeflexia hours after receiving dextrose-containing intravenous fluids, suggesting the development of refeeding syndrome. Refeeding syndrome occurs in the setting of hypophosphatemia, typically due to chronic malnutrition, alcohol use disorder, anorexia. Patients with alcohol use disorders are at particularly elevated risk due to alcohol-induced chronic diarrhea, reduces intestinal phosphate absorption, and gastritis. Calcium-based antacids bind intestinal phosphorus. The reintroduction of carbohydrates, i.e. 5% dextrose-containing intravenous fluids in patients with chronic hypophosphatemia leads to increased insulin secretion. This stimulates the intracellular shift of electrolytes, i.e. phosphate, potassium, magnesium, and increases phosphate utilization during glycolysis, formation of AT2,3-dephosphoglyceride, resulting in phosphate depletion and failure of cellular energy metabolism. Manifestations include muscle weakness, hyporeflexia, rhabdomyolysis, hemolysis, arrhythmias, and congestive heart failure. In addition to hypophosphatemia, hypokalemia, hypomagnesemia, and elevated liver function studies are typical. The diagnosis is confirmed with low serum phosphorus levels, and management includes close laboratory monitoring of electrolytes with aggressive electrolyte repletion. Refeeding syndrome occurs after the reintroduction of carbohydrates in patients with chronic malnourishment. Clinical manifestations include hypophosphatemia and other electrolyte abnormalities, muscle weakness, hyporeflexia, arrhythmias, and/or congestive heart failure. A 5-year-old girl is brought to the office for evaluation of pubic hair. Her mother noticed dark hair under the girl's arms and in her pubic area several days ago when helping her bathe. The patient has no headaches, visual changes, abdominal pain, or behavioral changes. She is obese and currently on a diet and exercise program. Several maternal relatives have type 2 diabetes mellitus. The patient's height has been tracking along the 50th percentile and weight at the 97th percentile. Physical examination shows a cooperative girl with mild facial acne. No breast buds are palpable. She has dark coarse hair across the pubis and under both axillae. External genitalia appear normal. Bone age is normal. Which of the following is the most likely diagnosis for this patient?
The fuck if I know? Must be like some sort of fucking X-linked. Would that be X-linked? Well, maybe it's mitochondrial? Are any of these mitochondrial? Not that I know of. Armpits, pubes, that's it. It's got to be something prolactin related. Hypothalamus glioma? I don't know. Harmatome, what the fuck is that? Fuck it. Let's go. Yo. Sometimes you're just better.
Development of secondary sexual characteristics is premature, i.e. precocious in girls age 8 and boys age 9. Obese children are at high risk for precocious development as adiposity can trigger excess insulin production, which then stimulates the adrenal glands to produce sex hormones. Isolated premature adrenarche is caused by early activation of adrenal androgens. Typical manifestations include body odor, oily skin acne, and pubic and axillary hair. However, estrogen and testosterone levels remain normal. Therefore, there are no other signs of premature puberty. Egg, breast development, testicular enlargement or virilization. Egg clitoromically. Mildly elevated dehydroepiandrosterone sulfate present in children with premature adrenarche is not sufficient to affect skeletal growth. Therefore, bone age is normal in these patients. Isolated premature adrenarche is generally benign but a risk factor for developing polycystic ovary syndrome, type 2 diabetes mellitus, and metabolic syndrome, especially in obese patients. Premature adrenarche is caused by early activation of adrenal androgens and is more common in obese children. Typical presentation includes precocious development of pubic and axillary hair acne, and body odor in a child with a normal bone age.
Interesting.
This item has associated media that may require the use of headphones. Please ensure your system speaker volume is set to an audible level. A 54-year-old man with a history of type 2 diabetes mellitus comes to the emergency department due to shortness of breath. Blood pressure is 146/92 mmHg, and respirations are 26/min. Oxygen saturation is 87% on room air. Auscultation findings over the cardiac apex are given below. Based on the auscultation findings, which of the following is the best? Initial therapy for this patient? Play media.
Something mitral. Shortness of breath. Initial therapy. Fuck. I don't know, bro. Extra. That's an extra gallop, bro? There's no way. That S1 sounds fucking bad though. It's like brr. I don't know. That's S3 though? Come on. Let me hear this. This has got to be, please be S for Cal. Come on. Come on. Okay, that's just too fast though. Come on. No, these are like, it would be like S1, or like S4, S1, S2. S4, S1, S2. I don't know if these are the right sounds to be listening to right now. I'm just going to... I don't know.
Educational objective. An S3 is a low-pitch extra hard sound heard in early diastole, just after S2. It is thought to represent reverberant sound created by blood filling an enlarged ventricle during passive diastolic filling, and it is commonly indicative of decompensated heart failure with reduced ejection fraction.
I don't even know, bro.
A 5-year-old boy is brought to the emergency department due to right-sided hemiplegia. His parents say that he has been having increasing difficulty moving his right arm and leg over the past 3 hours. This morning, approximately 10 hours prior, the child tripped on a toy while brushing his teeth and fell forward with the toothbrush in his mouth.
Oh, Jesus.
He cried immediately, but his parents did not note any oral bleeding. The boy did say, "My throat hurts throughout the day," but was able to eat his lunch. The child has a history of attention deficit hyperactivity disorder for which he takes methylphenidate. The boy's mother has a history of migraines, and his grandfather had a stroke at age 62. Neurologic examination shows right hemiplegia, right hemianesthesia, and mild motor aphasia. Which of the following is the most likely cause of this patient's condition?
The fuck is going on? What? The fuck? Who the hell? I don't know what this is, bro. Focal seizure? No. What? Like, what is this? I mean, like, yeah, that was like, bruh. They're saying this is a thunderclap headache? No, dude. But like, okay. Interesting.
This patient's symptoms of hemiparesis and aphasia after injury to the posterior pharynx are suspicious for an injury to the cervical internal carotid artery, which is located directly lateral and posterior to the tonsillar pillars. Carotid artery dissection is a rare but potentially severe complication of penetrating trauma, seemingly minor or pharyngeal trauma, egg befall with object in mouth, or neck strain manipulation, egg yoga sports. Intimal injury to the internal carotid artery can result in dissection or thrombus formation, which occurs over hours to days, and can extend into the middle and interior cerebral arteries. Patients may develop neck pain, thunderclap headache, and symptoms of an ischemic stroke, egg, hemiparesis, facial droop aphasia. The diagnosis of a carotid artery dissection is confirmed with CT or MR angiography.
Interesting. Interesting very much.
Posterior oropharyngeal injuries can result in internal carotid artery dissection or thrombus formation, which can present with hemiplegia, facial droop, and aphasia.